Good evening, everyone. Let me take the chance to introduce myself. My name is Hoàng Duy Tân, the sixth year medical student, and thanks to Dr. Nguyen and my coworker. So today I have a cardiovascular care report to present to you. Patient information. Patient name Lê Thị Tưởng, 57 years old. Her occupation is a housewife. Her address is in Hưng Lợi, Ninh Kiều, Cần Thơ, and she was admitted to Cần Thơ Central General Hospital at 4:45 p.m. August 19, 2018. Chief complaint: epigastric pain. Present illness: 5 days before admission, she had a back pain and knee pain. Thus, she bought some painkillers consisting of Alasan, ibuprofen, and paracetamol from the local drugstore without any prescription. Then she took it orally twice a day on the 5 consecutive days. 2 hours before admission, after eating fully and taking Alasan, she suddenly had a epigastric pain accompanied with short sternal heartburn. She took one phospholugel pack and the pain went out partially for a while. 1 hour later, the epigastric pain came back and tried the attitude back without positional release or associated factors. Then she presented with swelling, anxiety, and nausea. And then she was admitted to 121 military hospital. Diagnosis. So, diagnosis: acute inferior MI, Calip 1, second hour, with PP 110 per 70 mm mercury, heart rate 64 ppm, no range, no murmurs. Medication: enoxaparin, IV bolus, ticagrelor, aspirin, and Lipitor. Then she was brought to Cần Thơ General Hospital. Admission status: conscious and well-oriented, complaining of epigastric pain without any abdominal tenderness, no jugular vein detention, no murmur, no edema, no rounds, clear lung fields, and defined to size PP 95 per 60 mm mercury, heart rate 70 bpm, respiratory rate 20 ppm, and temperature 37 degrees Celsius, and saturation of oxygen 98% in normal condition. So it's the first ECG at the emergency department. Normal acid deviation, sinus rhythm, regular bradycardia with rate 59 ppm, and we can see the party waves in D2, 3, and AVF. So conclusion: junctional rhythm and acute inferior myocardial infarction. So we indicate with 3 and 4 in the right side. Diagnosis: I think we have enough evidence to make a diagnosis at the emergency department. Acute inferior SLMI, Calip 1, in 10 hours. May and C were medicated. Sodium chloride infusion, enoxaparin, clopidogrel, aspirin, captopril, pantoprazole, antacid, atorvastatin, and ezetimibe, some kind of cholesterol regulator. But medical history: internal medical problem, degenerative lumbar spine disease in 5 years, treating frequently by southern medicine and some kind of western drugs. Hypertension, diabetes mellitus, CAD unremarkable, but surgery, allergy, and family history unremarkable. Social history: no alcohol, no smoking. Physical examination. Physical examination at the 3 days after treatment. General appearance: consciousness, diaphoresis, anxiety, regional pain, orthopnea, and central cyanosis. No cutaneous hemorrhage, no edema, and the vital sign. We concern patient with shock with the PP 90 by 60 mm mercury, heart rate 60 ppm, saturation of oxygen 96% in the normal condition, respiratory rate 30 ppm, temperature 37 degrees Celsius, and BMI, the medium body status. Hint: head, ear, nose and throat, eyes, neck are normal. Abdominal, genitourinary, neurology and urology normal. Cardiovascular, patient got a GVD against semi-flawless position. Respiratory, use of accessory muscle and more trends in bilateral lower lung. Problems pattern. Female patient 57 years old were brought to hospital because of epigastric pain. Documented problems after doing history and physical. Acute coronary syndrome. Acute respiratory failure. Hypertension with GVD. So we need more tests to prove our diagnosis. ECG with 3, 3 and 4 in the right side lid. Submarine T, CKMB, transthoracic echocardiogram, abdominal ultrasound, and tract X-ray. They should be enhanced. And following the many biochemical tests. Here the first ECG at the emergency department with the acute inferior myocardial infarction and junctional lithium. So we can see the PDWA are clearly visible in D3, 4 and AVF, the red, and mirror STD present in D1 and AVL lead, the blue. Junctional rhythm criteria and causes. Junctional rhythm should be divided into 3 groups: cardiac disorders, use of certain drugs, others. In this case, inferior one myocardial infarction. Let's review the mechanism of junctional rhythm. Essentially, the intrinsic firing rate decrease from SA node to Burkitt fibers, and normally this SA node will be the boss. I mean the beat controller. If the SA nodal cells become suppressed, another latent pacemaker cells can drive the heart rate. In this case, AV node will perform junctional rhythm. So the second ECG 3 hours later. Normal acid deviation, regular sinus rhythm with rate 69 ppm, PDWA in D2, 3 and AVF, PR interval equal to 7 small box. Acute inferior MI, first degree AV block, so we suggest V3 and 4 in the right side leads. The third ECG 9 hours later, the same. Here the fourth ECG after 3 days later with V3 and 4 in the right side lead. This ECG indicates right ventricular MI and junctional rhythm come back. So our patient had shock, clear lung, elevated jugular venous, and SC elevation in the right side lead. So the diagnosis and management at the emergency department is alright. And there are things that we should to keep in mind that nitroglycerin is contraindicated in right ventricular MI, and approximately 25 to 50% of case of inferior one myocardial infarction are associated with a right ventricular myocardial infarction, according to NCBI. But it so said that um, just after 3 days, we had just got the V3 and 4 in the right side. Here, these figures show us the anatomy of coronary artery related to the EGG lead. Based on the anatomy, the sinoatrial node was supplied from 60% from the right coronary artery, and the arterioventricular node was supplied 90% from right coronary artery. So we can understand clearly what happened with the previous ECG. Here are thoracic echocardiogram. The normal EF, normal PAPS, and abnormal inferior and posterior wall motion. Abdominal ultrasonography indicate hepatocardiac disease, mild pleural effusion. Check X-ray PA position, bilateral costoplanic angle, blunting, and no enlargement of cardiac shield. Aortic arch, no dilation, mild pleural effusion. We got the cardio biomarker in troponin T and CKMB. They were illustrated in line chart, and they indicate the dynamic change. We can see the troponin T and CKMB, both of them increase significantly, and 3 days later they become decreased, and the dynamic change is adequate to then beside figures. The liver enzyme increased significantly and higher for AST, and the bilirubin and blood ammonia is also increased. Coagulation in both pathways were also affected, maybe due to the liver failure or the coagulation drugs. Renal function in the first period, the urea increased lonely, so it may be related to hypertension or pre-renal uremia, and then the urea and creatinine increase both, so we concern pre-renal uremia with renal disease or renal dam, and the electrolytes were not managed appropriately. And here some remain tests. Final diagnosis. So now we have enough evidence to make a final diagnosis. Acute inferior and posterior stomy and right ventricular MI, KLIP 4, third day. Drug-induced acute liver failure, hyperammonemia, coagulation disorder, and hyponatremia. Kili for cardiogenic shock had 81 mortality within a month. Treatment and plan. Goals of therapy. Maintain vital signs. Reperfusion as soon as possible with PCI or fibrinolytic therapy. Balance fluids intake and output and electrolyte. Improve coronary perfusion by drugs. Prevent thrombus formation and CVC placement to for monitoring and infusion fluid. Fibrinolysis is too late, so the PCI should be enhanced. At the first time, our patients should be classified in the group to get the early PCI, but we missed the first chance, and now our patients were classified in the group, and this group is not indicated for PCI. Our patient had a poor outcome. Before PCI, the first Medicaid contact is so important with the combination of aspirin, Flavis, and heparin IV, and morphine in case we need. But we have to but but we have to in, be careful with Richard and beta blocker. So medication, oxygen, sodium chloride infusion, enoxaparin, clopidogrel, aspirin, captopril, pantoprazole, dufalac, atorvastatin, and ezetimibe is no longer. Supporting liver health, silymarin and PMS use sodium. Nutrition, nutrient soup can meal via natural gadget tube. You know that administration of an ACE inhibitor within 3 to 16 days of infection can slow the progression of cardiovascular disease and improve the survival rate by prevent infection expansion, ventricular remodeling, according to up to date. Mm, with the low dose of statin, it cannot increase the liver enzymes. If the liver enzyme increase threefold, it's okay. Keep taking statin and reject liver enzyme. But in the case, you can see the liver enzyme surge increase significantly, so we better stop it. Although statin had a lot of excellent effect in early secondary prevention and it become a first-line therapy in ACS. Progress of illnesses. Our patients were brought to the intensive care unit. Admission status: unconsciousness, use of accessory muscle, jugular vein distension, more strain in bilateral lower lung. Vital sign: our patient was in shock with BP 80 per 50 mm mercury, heart rate 70 ppm, saturation oxygen 97% in oxygen 5 liters per minute, respire rate 30 ppm, temperature 37 degrees Celsius, and the air blood gas indicate the metabolic acidosis with normal ion gap, and the lactate serum lactate higher. The lactate and air blood gas indicate a decreasing of organ blood flow. Well, the blood glucose and electrolyte were not attempted appropriately. The electrolyte decreased significantly without any management, so do the blood glucose. And the liver enzyme bilirubin and blood ammonia increase. So diagnosed at the emergent intensive care unit. Cryogenic shock against right ventricular myocardial infarction in third day. Drug-induced acute liver failure, hyperammoniemia, severe hyponatremia, hyperglycemia, and metabolic acidosis. Progression and treatment. When admitted, our patient was shocked, so we indicate dopamine infusion siren electrical with the dose 3 ml per hour. 3 hours later, the PP go up into normal range, so we changed into the dopamine uh, with the dose of 3.6 milliliter per hour, equal to 5 microgram per kilogram per minus. And 6 hours later, the PP goes down, so we indicate dopamine with the double dose, and we insert noradrenaline. 9 hours later, the PP patient was still in shock and heart rate go down, so we indicate dopamine and noradrenaline within the double dose. So take home message: be aware of epigastric pain caused with inferior 1 MI. NSAIDs except aspirin can increase risk of heart attack. 25 to 50% of right ventricular MI is associated with inferior 1 MI. So we always indicate V3 and 4 in the right side. Right ventricular MI and inferior 1 MI may be the cause of bradycardia or kind of sinus arrhythmia. Right ventricular MI is contraindicated with beta blocker and recharge. ACEIs improve survival after MI by reduced infarct expansion and ventricular remodeling. Statins is the first line therapy and the early secondary prevention in ACS with multi effect. So we have a lot of questions to discuss, such as what is the actual cause of liver enzyme elevation, and which one could lead patient into unconsciousness, shock, hyponatremia, hyperammonia, and hyperglycemia. So thank you.